All right, well. One, two, three. Everybody hear me all right? All right, well, thank you very much to Ken and also to Perry for organizing this particular symposium. I think Ken's comment that schema therapy is in some way a blending of many aspects of DBT with some aspects of psychodynamic or TFP is partially true, and I think that it does take a middle ground, whereas I think DBT focuses a lot on the external behavior, particularly dysfunctional emotional behavior, and whereas TFP focuses a lot on the underlying deep dynamics of the case, I think in schema therapy we're trying to do both. We're trying to both work with the external behaviors and help a patient to learn to cope with their emotions better, but we're also trying to help them make deeper personality change so that at the end of therapy they haven't just stopped cutting or stopped hurting themselves, they're actually happy, fulfilled people in their lives. And I feel that this is the goal of schema therapy, and I think it is in some ways different. Also, I think a primary difference, and I'll start with the actual presentation, is the central role of the therapy relationship. I do think with BPD, the primary mechanism of change, probably in all three treatments actually, is probably the nature of the relationship between the therapist and the patient. And I'm going to argue that the limited reparenting approach that we use in schema therapy will ultimately be the most effective strategy for bringing about long-term personality change in BPD. All right, I'm going to first give you a very quick overview of schema therapy, since many of you may not know what it is at all. And then I'm going to focus on schema therapy for BPD. So to begin, that's just thanking NEAPD for inviting me. This is a definition of schema therapy. It's also called schema-focused therapy. There's no real difference between the two. I used to call it schema-focused therapy. Now I call it schema therapy. Basically, the key things on this slide is that it is an integrated, unifying treatment designed for characterological problems. And as you can see, it combines cognitive behavioral, attachment, psychodynamic, and emotion focus, which are like Gestalt techniques, all in one approach. We start with the construct of core emotional needs. And so rather than starting with the construct of emotional dysregulation, or starting with a construct of core internal conflicts, we start by saying that every child comes into the world with the same basic emotional needs. A need for safety, a need for a stable base, a need for love, for acceptance and praise, for empathy, limits, and for validation of their needs and feelings. And we say that when these needs are not met in the early childhood environment of a patient or any of us, the person develops specific early maladaptive schemas as a result of the needs not being met. And for each need that isn't met, we've developed a particular schema. So the next slide shows you, I'm going to skip this definition of a schema. A schema basically is a core theme or a life pattern. So here are here are the 18 core themes, life patterns, or schemas that we've identified across all patients, not just with BPD. And what's important is that this is a model that's a model that's made to account for all people, not just quote patients. It's a model. It's a normalizing model. We all have these needs. We all have schemas. It's a question of which schemas and how severe they are. So it's a very normalizing way, and that's very helpful to a client to understand the problems they have are along a normal spectrum. They're maybe at the extreme end of the spectrum, but nevertheless, it's not that their problems are freakish or weird. They're just more extreme than the average person. And some of the most common schemas that we see in BPD, although we see them in many other disorders as well, The first important thing that differentiates BPD from other disorders is that when we give patients with BPD a schema questionnaire that I developed, they score high on almost every one of the 18 schemas. And there's no other diagnostic category or Axis 1 or Axis 2 category that is like this. So it's clear that one of the main differences is how many different core problems or core issues patients with BPD have. And that's one of the reasons I think they're very challenging to work with. Just to mention a few of them, the issue of abandonment, feeling that they're always going to be left, that people are not going to continue to love them, care for them, or stay with them. The feeling of mistrust and abuse, that people are going to hurt them, that they can't trust people because people are going to do things to damage them or abuse them. A sense of emotional deprivation. They didn't get affection. They didn't get listened to. They didn't get protected. And the sense of defectiveness. The sense that deep down they're bad people. These are some of the central schemas that we see in BPD patients. Now, the third construct, we talked about needs and schemas. The third construct are schema modes. And these were developed, this construct, specifically for my working with BPD patients, and realizing that the original schema model was not adequate because BPD patients were in some ways different. And I tried to figure out a construct that would help me describe those differences. This slide defines it. It's a little bit complicated the way I worded it, but it's those specific emotions, cognitions, and behaviors that are currently active for an individual. So whatever, for example, a patient in your office or in our offices is feeling, thinking, and doing at a given point in time is the mode they are currently in. So the mode is the state that the patient is in. It's whatever schemas are currently activated for the patient. It's whatever coping responses or healthy reactions they're using to cope with those schemas that are activated. Borderline patients with BPD flip from mode to mode. That's where I think the emotional dysregulation does play a role. There is a constant flipping from mode to mode, much more so than in other disorders. And it's similar to the concept of ego states, if you're familiar with that approach. It's not the same. But if you think of as modes as different parts of the self, and then we all have different parts of the self, and we're trying to figure out for a given patient what parts of the self are most central to their personality organization. So these are the modes that we've identified in almost all BPD patients. And I'm going to go through them in more detail a little bit later. They are the abandoned or abused child mode, the angry and impulsive child mode, the punitive parent mode, and the detached protector mode, and to some degree the healthy adult mode. And the notion is that the BPD patients, what's happening is they're continuously flipping from one of these modes to another. And the basic idea of the therapy, as you'll see, is to help them become aware of which modes they're in at a given point in time, and to learn how to cope best with that mode by our modeling how to deal with that particular mode. The broad goal of schema therapy is to help patients get their core needs met in an adaptive manner by changing maladaptive schemas and modes. So note that the primary goal is not the reduction, is not only the reduction in the acting out behaviors. The primary goal is to help the patient get the core needs met that I mentioned in the first slide that you saw earlier. This is an overview of the change strategies. I'm just going to mention them quickly. Limited reparenting, which we're going to spend a lot of time, well, you don't have a lot of time to do anything, but I'll spend a little more time on that than other things. Cognitive restructuring, emotion-focused techniques with Gestalt therapy, behavioral life pattern change, trying to change life patterns, and schema mode work, which I'll explain a little bit more about later. All right, now we're going to talk about chemotherapy for BPD in particular. That was our general model across all patients. So this is our conceptual model and philosophy of people working with BPD. The modes I already mentioned. Now we're going to go through them one at a time, and I'm going to mention how the case of Janet might fit some of these particular modes, although there isn't enough data in that short sample for us to pick up very strong indicators of each of the four modes. So let's look at them individually. When a borderline patient, I know that the correct way is borderline BPD patient. Unfortunately, when I originally started doing it, I called it borderline patient. So I apologize if I say it by mistake. It does not mean it's not in any way meant to be insulting or uncaring. When a BPD patient is in an attached protector mode, it's very hard to tell because a lot of therapists mistake this for a healthy adult mode. Because in order for a BPD patient to survive in the world, they have to learn to shut their emotions off. They have to learn to to shut the angry child off, to shut that abandoned child off, and to shut the punitive parent mode off. If they don't shut them off, they can't function and do work and function in the everyday world. So when they're in the detached protector mode, they're basically emotionally numb. They don't feel anything. So basically, you'll notice symptoms like depersonalization, emptiness, boredom, substance abuse, self-mutilation, all of which are symptoms of being detached. And these are some indicators in the case of Jane of her being, at least sometimes, in this particular mode. She cut herself with her father's razor at age 14 to relieve some of the tension she experienced. Many of our BPD patients will say they cut themselves because the emotions were so overwhelming that they actually felt that the physical pain feels better than the emotional pain. And what that's really saying is that the cutting is a way of detaching from emotions. So we say it can be part of the detached protector mode. She also said the evaluation that she's seen withdrawn at first. It's typical of BPD patients at the beginning to act polite, to go through the motions of doing what they're supposed to be doing, but they don't feel anything. And that's, again, part of the detached protector mode. And finally, she's very overweight and overeating. I think that overeating with BPD patients is often, although not always, a way of numbing themselves to painful emotions. The second mode, and I think really the core mode for BPD patients, is the abandoned or abused child mode. This is the mode in which BPD patients feel helpless to get their needs met and or to find protection. And as you can see, some of the symptoms are depression, feeling hopeless, needy, frightened, victimized, worthless, unloved, and making frantic efforts to avoid abandonment by the people who they depend on. These are examples from the case of Jane. I've changed the name a little bit for the lonely, unloved child. We modify the names of the mode to fit the particular patient a little bit better. But indicators of this mode: depression unresponsive to medication or relatively unresponsive. This is typical of BPD patients. They have, in this mode, a lot of dysphoric affect and sad affect, but it's relatively unresponsive to medication. In fact, one study that's about to be published showed that patients who got chemotherapy and were also on medications did dramatically worse than the ones who got chemotherapy and were not on medications. So the medications were not only neutral, they were clearly negative. They actually had a distinctly negative impact. In fact, it was 20 or 30% less effective, the therapy, with the patients who were also on medications. A third is that she made a suicide attempt after a breakup with her boyfriend. It's very typical of borderline patients when they're in this abandoned child mode. The biggest trigger is being abandoned. It is being left by a boyfriend or breaking up with a boyfriend and then feeling alone again. She was tearful and remorseful at her evaluation. The tearfulness, the remorsefulness was part of what the patient feels when they're in that vulnerable mode. She felt unpopular at school. Popularity is part of that feeling of being unloved or lonely. She tried but failed to gain her mother's affection, very common. Typically, although I know some of you may be parents of BPD patients, typically BPD patients experience one or both parents as unaffectionate and not nurturing. And therefore they strive very hard to gain the affection sometimes of that parent. It's usually an indication that there wasn't enough affection early on. And also she tried to gain her parents' affection by becoming a nurse. The third mode is the punitive parent mode. And in this mode, the borderline patient punishes herself for expressing needs and feelings or for making mistakes. And in this mode, the borderline patient shows a lot of self-hatred, self-criticism, self-denial, self-mutilation, and angered herself for becoming needy. We didn't have much evidence of this in the case material. However, she was described as showing a lot of worthlessness and feeling self-disgust. And self-disgust is a very good description of what BPD patients feel when they're in the punitive parent mode. The last mode is the angry and impulsive child mode. Oops. Sorry. This is the mode in which BPD patients act impulsively to get their needs met or to vent feelings in what are usually inappropriate ways. And I don't need to give you the symptoms of that mode, it's quite obvious. Case of Jane, the indicators that she has this mode: her difficulties with staff at the mental health center. She made official complaints. She was angry and hostile during the evaluation, and she felt used and presumably angry at her mother and boyfriend. Okay, these are the hypothesized origins. The important thing to note the family environment being unsafe, emotionally depriving, harshly punitive, and invalidating. We also have biological origin, high emotional intensity, and lability. One difference that's a big difference, I think, with DBT is that we place more of the emphasis, the origin of the disorder, on the family of origin. We do believe it's an interaction of the two, but in terms of the relative emphasis, we put more emphasis on the family of origin than we do on the biological predisposition. And here are some possible family and peer origins. But Jane, the parents were more concerned with appearances than with the emotional welfare of the child. Her mother was critical and overbearing. She was unpopular at school, teased about her weight. These were the peer origins. The parents compared her negatively to her siblings repeatedly and criticized her about her weight and academic performance. And they were apparently unloving in that she felt she tried to earn their love, but said she couldn't. Our philosophy of treatment, this is central to the whole model, to view the patient emotionally as a vulnerable child. And we tell our therapists, when you get angry at a BPD patient, instead of getting angry as if they're an adult, superimpose an image of a young child in the face of a BPD patient, and that will help you to understand that no matter how upsetting their reaction may be to you, it's not coming out of a desire to hurt you. It's coming out of a child's emotional reaction to feeling that their needs are not being met. We believe that borderline patients are genuinely needy, not greedy. Their needs were not met, and they're trying to get them met. The therapist has rights too, meaning we do have a right to set limits. Don't blame anyone when they're frustrated. I think more borderline patients get worse in therapy because the therapist ends up blaming them instead of actually being patient and accepting many of their behaviors. Treatment parallels child development means that BPD patients in our model emotionally begin usually at the age of 2, 3, or 4, and during the course of the treatment, developmentally progress. And then also, finally, the importance of mutual respect and genuineness. We say if you don't show enough respect or enough genuineness with the patient, the therapy will not be effective. This is the actual treatment approach itself. There are 3 stages: bonding and stabilization, schema, mode change, and autonomy. How much time do I have after that? Okay, great. I want to be sure to get the later slides. So, I'm going to go through each of these stages, but I'm only going to touch briefly on some aspects of the stages. The first is bonding and social and stabilization. Bonding is the need to form this close reparenting relationship I'm going to talk about. Bypassing the detached protector means that BPD patients come into treatment shutting off their emotions because they don't trust the therapist. So a lot of what we're trying to do early on is to earn the trust of a BPD patient by being honest, genuine, caring, and pointing out to them that they're in a detached mode and what the function of that mode is. We focus on healing the abandoned child mode. That's central to the therapy. We think if we can heal the abandoned child mode, the patient will get better. If we can't, that they simply don't. And lastly, dealing with suicidal and parasuicidal behaviors, that's part of the stabilization. And how do we do this? Well, limited reparenting is our primary mechanism. And I need to say a little bit about what limited reparenting is. These are some of the components of it. One of it, like DBT, is validating needs and feelings. It is continuously showing BPD patients that you really do understand what they're feeling and also where those feelings came from and the type of suffering they've actually had in their life. Another is that we become their nurturing, stable base. By becoming the parenting figure, we take over the role of the parent, essentially. We become the stable base. We're the person they turn to. We provide the consistency during the course of the therapy. We do a lot of direct praise of patients, which a lot of therapists think is a bad idea. If there's something I like in a BPD patient, I will tell her, you know, I really like this quality in you, or I really think it's great that you did this. So I think that the therapist's willingness to sort of say what they really feel and to not be afraid to directly praise a patient is an important part of the parenting. This next element is really difficult for most therapists because most therapists are taught to play the role of a therapist rather than to be a real person. And what we're trying to do, and it's very hard to do, is to teach therapists to stop being therapists in some respects. We're trying to teach them to learn to have a real relationship with the client based on honesty, directness, and genuineness. And that's, I think, one of the primary reasons we are successful is that it is a real relationship and it doesn't sound canned or kind of like as if you're reading a script or going through a protocol or a manual. The borderline patient feels as if, which is true, that we care, we really do care about them, and that I will tell them what I really feel. And that I'm not going to sort of pussyfoot around walking on eggshells. I'm going to be polite and kind, but still I'm going to say what I basically feel. Appropriate self-disclosure, the willingness to share your own life when it's appropriate, the willingness to share your own experiences, to share your own reactions to what the client's doing. This again promotes limited reparenting. Well, these are standard things, but now we go beyond that with BPD patients, and this I call reparenting beyond the call of duty. These aren't all necessary, but they're things we do with many of our BPD patients, not all of them. One is giving out a home phone number. We do this with all of our patients, so it's a central part of all of schema therapy. Extra time. We don't think, they see the therapist twice a week, but there's lots of time outside the sessions. Phone time, I get emails all the time from BPD patients and other patients, and dealing with crises outside. We give them transitional objects if they want them. If I go away on a vacation, I might give a patient a pen that I use, or they might take a photograph, or they might make a tape recording. And that way they have a way of remembering me. And also I'll often talk to them in scheduled sessions when I'm on a vacation, because the notion is they have trouble maintaining a sense of constancy if you're away for too long a time. So we try to provide something to maintain the consistency over time. We tell the therapists to ask themselves when they don't know what to do, what would a healthy parent do for a young child? Not what would a therapist do, what would a healthy parent do? And if the therapists ask themselves this question, we feel they're much more likely to get good results with a BPD patient than if they try to be their image of the correct therapist. We do a lot of reparenting through imagery, which I don't have time to explain now, and limited holding. There are instances in which we'll put our arms around patients. I actually have a tape of it, we have time to show it, if the patient gives permission and when it's appropriate. So for example, if a client were crying all through a session, I might say, would you like me to come over and put my arm around you? And if she says yes, then I'll go over and just sit next to her, put my arm around her until she feels better, and then just go back to my seat. Also, almost all of my BPD patients will give me some kind of hug at the end of the session. I never start by initiating it, but on the other hand, it seems to be very meaningful for the patient, and since we do develop a close bond, it feels natural to do this. A little bit about handling suicidal crises. I can't obviously go through every aspect of the model, but I think the key element here that's different from other models is that once again, we're relying on the frequency of contact with the therapist. So that when there's suicidal or parasuicidal behavior, we want the patient to call us and talk to us. And during that time, we figure out which of the modes they're in and work with them on those modes to help them through the crisis. And we find that usually that's enough. We're not against teaching the DBT skills if it's necessary, but generally the relationship itself is enough to help them through most crises. And in terms of the case of Jane, this is a schema-focused treatment plan. It's rather general because I don't know much about the case, but we would utilize limited reparenting to build trust. We would explain the mode approach and teach her to monitor her mode flipping. We use techniques from cognitive therapy to reduce the level of depression. We practice imagery work with childhood and adolescent memories to help her stop detaching and to learn how to reparent the lonely child. The patient initiates phone contact when she feels like self-mutilating. We identify the mode that she's in at the time and utilize schema strategies for that mode, and we add DBT techniques if necessary for self-mutilation. The second stage in working with BPD using schema therapy is what we call schema mode change. In the first phase, we worked a lot on creating the reparenting relationship, on trying to bond with the patient, trying to overcome what I call that detached protector where they don't quite trust you and they're keeping a kind of a wall up. And also a lot of work working with what I call the abandoned child or abused child and trying to let them do the memory work where they remember what it was like as children, and we try to do reparenting in imagery and in the session. And that can take easily a year of the treatment can be just spent in that first phase. Then, as we move into this next phase of the treatment, as you can see on the slide, we call this schema mode change because now we're focusing on the two remaining modes, which are the punitive parent, combating the punitive parent, and working with the angry and impulsive child. So let's talk about a little bit, again it's just an overview, but a little bit about what we do with the punitive parent, and then a little bit about what we do with the angry and impulsive child. And as you can see in this slide, there are several different steps in working with the punitive parent. Basically, remember, this is the mode in which the borderline patient is telling herself how bad she is. And usually it's saying things like, I'm horrible, I don't deserve to live, I'm despicable. It's not just saying, I'm not a good person. It's much more anger directed at the self. So these are some of the steps that we follow when they're in this particular mode. First of all is to educate BPD patients about universal needs and feelings. This is something that they also do in DBT, and it's very important because BPD patients were often brought up in families where
they were given the message, either overtly or covertly, that it's bad to express your needs and bad to express your feelings. We're trying to teach them in the beginning of working with this mode that it's natural to have emotion. It's natural to cry when you're sad. It's natural to be angry when people do things to you that hurt you. And and it's natural to ask someone to give you a hug. It's natural to ask someone to praise you. And that this does not make you a bad person. It doesn't make you a needy, bad person. And for many borderline patients, this is the first time they've actually heard that, because they so much were told as children that this is bad, that whenever they begin to express a need to a friend, to a partner, they then shift into the punitive parent mode and get extremely angry at themselves for being needy. And we're trying to say, no, you don't punish yourself for being needy. It's natural to have these needs, and it's good that you're expressing it. We just have to teach you healthy ways to ask for it. A second part is the way we explain the punitive parent mode. We explain it as an internalization of an actual parenting figure in their childhood. And we'll try to get them to identify which parent or person in their childhood has the tone of voice they use when they talk to themselves in this mode. So usually I'll repeat back to them what they sound like when they're in this mode, like something like, you're lazy, you're good for nothing. And then I'll say to them, whose voice does that sound like from your childhood? And they usually very readily can say, well, that's my father, or that's my grandfather, or my uncle, whoever it is. And I'll say, well, then let's call this your punishing father mode. And whenever you start getting angry at yourself, instead of thinking of it as this is you talking to yourself, think of this as this is your parent talking to you in this angry, punitive way. And that's going to help us take this punitive voice that you have inside of yourself and put it outside of yourself so you can talk to it, argue with it, fight it, instead of just accepting that it's valid and giving into it. We work a lot on reattributing childhood rejection to parents' issues. Very many borderline patients, when they're young, were rejected. Sometimes subtly, most of the time very overtly. One parent would just say, I don't care about you. They would completely ignore them. They would be extremely mean toward them. But the child gets a sense that there's something basically wrong with me because I've been rejected by my mother or my father. And what we're trying to get them to see is that there's really no such thing as an innately bad or evil child, at least not in the everyday world. And that the chances that they did something so bad as a child, or that they're inherently so bad that they deserve to be treated in this rejecting, punitive way, isn't realistic. And it's a very hard thing to do. But once we can get them to look at their parents' issues and look at how the parent treated their brothers, their sisters, and looking at the schemas of the parent, they begin to see the parent as not really being a good person to turn to assess whether they are good parents. And eventually, we hope they come to the conclusion that it's not that I was a bad child or I'm a bad person. It's that my parent didn't know how to parent me. And therefore, it's not my fault. I'm not bad. It was my parent who was bad in this particular respect. And once they can make that shift from blaming themselves and thinking they were the bad infant to believing that it's actually something in the way they were treated, it is a major turning point in the treatment. I already mentioned earlier the importance of the therapist constantly highlighting successes and positive qualities. It's extremely important for the therapist to tell the patient in a genuine way when they like what the patient has done, when there are qualities like loyalty, perhaps their artistic work, their extreme sensitivity to the feelings of other people. Many of these are wonderful qualities, and pointing it out to the BPD patient as a great quality and telling them you admire them for it or you think it's great that they're this way, again, also helps to fight that punitive voice that they're carrying around all the time. And finally, we do imagery work. with the punitive parent mode, in which we do it. I'm not going to go into all the details because it's an overview, but basically it's an image in which we have the little child who's being punished by the parent. We have the parent in the image. We create some kind of safety barrier between the parent and the patient, because most BPD patients don't feel safe enough to stay in the image if the parent is there getting angry at them. And then I come into the image as the kind of defender or whatever, protector, and I will stand next to the child in the image, and they will provide the voice for the punitive parent. And let's say it was the father who was punitive. I'd say, well, to the patient, I might say, "Judy, play your father now and say, tell me what he would say to you." And he might say something like, "You're no good, you're a loser, you know, your brother's so good, he's great at sports, and you're nothing. You know, I don't know why I even had you." So then I'll come in, then I will, while the patient is in the image as a little child, I will talk back to the parent and say, "No, it's not that Judy is a bad child. It's that you're a bad parent right now. A good parent doesn't say things like this to a child. And I'm not going to let you keep doing this to her. If you do keep doing this to her, I'm not going to let her be around you anymore because you're just a destructive influence on her." And by hearing me talk back to the parent that way, the patient begins to feel again that maybe the parent was wrong. Maybe when the parent said all these horrible things to them, maybe they really weren't true. And if the therapist can make a convincing enough point in doing these dialogues with the parent, again, the patient's punitive parent begins to drop. And the combination of these techniques are usually very effective over a long enough time in helping the patient to build their self-esteem and to reduce the strength of this punitive parent mode. And now going to the next mode is the angry child. And there are many things we do to work with the angry child mode, but I'm going to focus on what the therapist should do in our model when a borderline patient is angry toward the therapist, because as you know, we have the angry child mode, and even the smallest thing that a therapist does could be a trigger for a borderline patient to go into the angry child mode. So, for example, I had one patient where I forgot her birthday. She had told me the week before it would be her birthday, and the next week she comes in, and I'd forgotten to wish her happy birthday, and she was furious with me, and venting, expressing tremendous anger. I didn't care about her. Everything was phony. All I cared about was the money, that kind of thing. And what I want to go through now are the steps that we follow when a borderline patient is in a mode like this in the session with the therapist. The first thing is that if the patient is actually being abusive or destructive, like they're throwing things, or they're saying things that are not just mean or angry, but actually abusive, like calling you, motherfucker or something like that, we set limits and say, no, you can't talk to us that way. I want you to be angry, but I'm not going to let you talk to me with words like that. So it is important to set limits so that the angry child mode, while we're working with it, that the patient understands the difference between venting anger versus being abusive or destructive. It also protects the therapist. Now, assuming that the borderline patient, which most of them are not abusive or destructive when they're in this mode, let's assume the example I just gave you with the patient where I forgot her birthday. These are the steps I'll follow in working with her. First of all, I'll just encourage her to get all the anger out. And just say, so you're feeling angry because I forgot your birthday. Why does that make you so angry? And then she'll go on and give me more anger. And I'll say, and what else are you angry at me about? And usually she'll come up with another thing. I'll say, and what else are you angry about? And we'll keep going until she says, well, that's about it. The notion being that so long as the borderline patient is experiencing the anger, they can't move to the other levels of change. Whereas if they can vent the anger, get it out and express it, then they're open to hearing other ways of dealing with the anger. So the second step after helping them to ventilate is to empathize with the underlying schemas. Because almost always when a BPD patient's angry at the therapist, they're angry because they feel as if the therapist is not meeting their core needs. It feels as if the therapist is not caring enough, isn't really listening to what they're saying, isn't taking them seriously, doesn't care about them. And so what we want to do is empathize with those underlying feelings instead of focusing on the anger itself. So I might say something like, well, Judy, I know that you're angry at me right now, but I can hear underneath the anger what you're upset about is feeling, I'll say little Judy, which is the abandoned child mode. I'll say little Judy right now is feeling upset because she feels I don't care about her, that she's wondering, am I just pretending to care about her? And no one's ever cared about her before, and she doesn't know if there's someone who really does. So that's the empathizing with the underlying core need. And then the final step after that, and often once you do that, the borderline patient you don't have to go any further. They'll say, I know that you care, and I know you just made a mistake. But if they don't, then we go to the last step, which is reality testing. And this would be involved in saying to the client something like, which involves separating out the realistic component of the anger from the exaggerated element. So I might say to Judy, I might say, well, look, I think you're justified in being angry that I forgot your birthday. I know how important it is to you, and I forgot, and I know that is hurtful, and I really genuinely apologize for doing that. It's important for the therapist to take responsibility when you do something that's hurtful to the patient, even though it was not intentional. It did hurt them, so apologizing is still a good thing to do. But then you need to point out where it's exaggerated and say, but the fact that I forgot your birthday doesn't mean that I don't care about you, that all I care about is the money. I said, because you're forgetting all the other things that I do. You're forgetting the extra sessions that I do on the phone that I don't even charge you for. You're forgetting the emails we do with each other. You're forgetting that I do phone sessions with you when I'm away on a trip, so you don't feel so alone during that time I'm alone. So it's hurtful to me, even though I know that you don't mean to hurt me. It's hurtful to me for you not to be able to also see that even though I forgot your birthday, in so many other ways I really have been caring toward you, and I really do care about you. And I'm not perfect. I can't be the perfect therapist for you, but that doesn't mean I don't care about you, and it doesn't mean that I'm doing it just for the money. And I'll say, how do you feel about that? And usually the combination of apologizing for the realistic component while pointing out the exaggerated component, particularly using personal self-disclosure, is a very effective way of helping the patient to see how they're distorting what the therapist is doing. It's very important then to share your personal reactions to the anger. And I'll say, I'm your therapist, and as a therapist, I understand what happens when you get into the angry child mode. I understand why you say these things. But it's still hurtful when you say it. And if I weren't your therapist and you talked to me the way you did today, I would probably pull away from you. And the reason that's so important is because outside of the session, most of the people you're going to meet are not therapists. So when they hear you getting angry like that, they're not going to be as forgiving. So it's really important that we work to help you to contain that anger, because when you express it in that way, it will drive people away. And most people have very low tolerance for anger. So we have to work very hard to help you to express your needs in a more appropriate way instead of in this angry, out of control way. So that's the main way in which we work with anger. The other step, last step, being to then practice assertion. Well, I'll actually say, let's start the session over again, and I want you to come into the session and practice it, but not doing it the way you actually did do it, but expressing that you were hurt by what I did, but without getting angry and attacking me. And then I'll demonstrate how I would say it and ask her, can she now practice saying it that way? So those are all the different steps in trying to work with the angry child. And then we, of course, work later on how to generalize those steps to relationships outside of the therapy relationship. And now just examples of how you might apply the punitive parent and angry child work in the case of Jane that we were discussing. Oops, sorry. For some reason it's not the slide isn't continuing. Oh, there it is. It did. So, oh no, it didn't. We're going to have to go back. It didn't continue. What's that?
It doesn't go back.
Well, they're going to want another case. Okay, so why don't we pause it and go back? The problem is when I pushed it, the slide didn't work. Okay, and then after we finished this second phase, the scheme of change phase, in which we're working with the punitive parent and the angry child, and now we're probably 2 years into treatment by the time we've done all of this, or a year and a half, depending on how high functioning the BPD patient is. Then we enter the last phase, which is the autonomy phase. By this point, the BPD patient is not really that much different from any other patient that you're working with, except there are some issues that are somewhat different in working with BPD patients. But the goal is to now move away from what's going on in the therapy relationship. Since the patient's much more stabilized, the modes are integrated by this point, and they're dramatically healthier. So now we turn to their outside life, because almost always with BPD patients, there's a lag time between the emotional change and the insights and what's happening in the therapy relationship and changes in their life outside. So now we make the last phase primarily focus on that. So we focus on behavior change outside of the therapy. Primarily and most importantly is developing a healthy relationship. We actually feel that until a BPD patient has developed a healthy, intimate, or romantic relationship, therapy is not really complete. Because most all of the BPD issues in relationships come up primarily in the context of intimate relationships. So if they don't have one, you really haven't completed their work, which is learning how to live day to day with somebody and learn to deal with times when their needs are met, and times when their needs aren't met, as happens in every relationship. So a lot of this time is spent helping them choose appropriate partners, since BPD patients tend to choose inappropriate partners. We try to help them recognize the signs of an appropriate partner. We'll often discuss I'll discuss who they're dating, and we'll develop a list of questions or ways they can sort of figure out, is this a good person for me or not? Then once they're in the relationship, we'll talk about any problems they had during the week, and we'll discuss, to what extent was it the partner's problem that came up, to what extent was it the issues of the patient, and how could the patient handle the situation better. And in some instances, we may even bring the partner into the session to work with us. Another part of the autonomy phase is individuation. This is really not a major part, but it is significant in that we want BPD patients to make good choices in other parts of their life, such as careers. Many BPD patients have made career choices, such as Jane, the case we talked about. They made it to please their parents. They made it because they felt it was the right thing to do, but not because it was in sync with their real needs and feelings. So we encourage them to rethink their careers and try to choose something that's rewarding for them and consistent with their nature. And you don't know what, of course, every person's nature is different, but we want them to choose a career for the right reasons. Choose it because it's fulfilling, not because someone else told them it was the right thing for them to do. And we're going to talk about the next thing on a separate slide, forgiving hurtful family members if possible, and meeting with supportive family members. We'll talk about that on the next slide. And finally, termination. This is a gradual process where we slowly decrease the frequency of sessions until eventually the patient doesn't have to come regularly anymore. We tell the patient we never use the word termination. We tell patients they're always free to come back whenever they want to, and I still care about them. They can send me emails. All it means is we don't have regularly scheduled sessions anymore. So they never experience the therapy as an abandoning the situation. Okay, so now let's go to the next slide. And this is just a little bit about working with the family members, and both in the past and in the present. It is helpful at this point because we're nearing the end of treatment. We want the patients, if possible, to be able to have satisfying relationships with their family members. And yet, in many cases, it was the parents or other family of origin members who were the source of many of their problems. And some may have abused them in the worst case scenarios. Some may just have been over-controlling or highly critical. But in any case, helping them to be able to forgive the people who did hurt them, which could also include peer group, forgiving the people who did hurt them, and being able to move on and not harbor the anger for what happened in the past is an important last step, or nearly last step in the treatment. We try to get them to look at the schemas and modes of their parents and other significant others to develop a more sympathetic view and understand what are the parents' own issues, what are their schemas, what are their modes. So that helps them to see that the parent is unintentionally treating them badly, just the parent is doing what they were taught to do, which goes to the next point, which is a legacy of schemas and families. We do think that schemas are passed along from generation to generation, and unless the parent at some point gets therapy, the cycle doesn't stop. So we explain to them that it's not the parent's fault that they passed along the schema to the patient. It was probably, if you go back to your grandparent, to their parent, they were treated the same way. And that's the legacy of schemas. And the point is not to blame the grandparent or the parent. The point is to stop the cycle now with people in your life, including your own children, if you should have it. Also, this sometimes involves grieving, because often they are feeling much better at this point, but a very common reaction is, I've spent 40 years of my life, 30 years of my life in terrible pain. Now I feel better, but that doesn't wipe out those 30 years of pain. And they often have to grieve and go through a process of remembering and crying and just feeling compassion for themselves, with me listening about how hard their life was, but that now they can move on from it. But grieving is an important step, because it's hard to move beyond the past when you're still stuck in the pain of the past. If there are still hurtful family members, for many BPD patients, one or more of the family members from their childhood is still hurtful, still critical, still pays no attention to them. And if that family member is not willing to accept responsibility and come in and get help as part of the therapy with the patient, then we encourage them to minimize the contact with hurtful family members to as little time as possible, because every time they're with the family member who treats them this way, it makes the modes and schemas stronger again and undermines the progress of the therapy. On the other hand, with supportive parents or family members who have now opened to the idea that they may have played some role in what happened to their child, if they're willing to come into sessions, it's very, very helpful and extremely powerful to have sessions with the patient and the family members. And what I'm really trying to get to the point in these sessions is to get the parent to explain their intentions in a positive way, but to also to apologize for whatever mistakes they did make as parents, recognizing that no parents are perfect. And a lot of parents are very, very defensive and aren't willing to do that. And if they're not willing to apologize, it's very hard for the BPD patient to forgive them and move on. On the other hand, many family members already recognize things they've done that weren't ideal with their children, and they relish a chance to come in and help their child. And the schema model is very helpful for them, because it lays out the needs that a child has and that their child still has. And we work on ways for them to do it. I remember one example of a patient where her mother was Chinese, and mother had been taught never to hold the child. You don't hold or show affection to the child, and that's how her mother had been with her. And I had many sessions where the mother would come in with her grown borderline patient and would just sit there hugging and holding the patient, which is something she'd never done when the patient was young. And we had sessions like that. Then they started scheduling time outside the session to do exactly the same thing. And it was probably more powerful than anything else that happened in the treatment, was the mother's willingness to do that and her desire actually to do that. So these sessions can be extremely valuable when the parent's willing to take some responsibility for changing. And the patient has to also sometimes recognize that they play their role in it as well, naturally. Okay. And now just, this boat, we can't look at that one, so let's skip that slide. Okay. And just a little bit, I'm not going to go through all of these. Just a main point of this slide is just to say that it's very important if you're doing schema therapy to have someone supervising you or working with you, another therapist, because it's very hard work and it's easy for your own schemas to get triggered. So a lot of what we do is help the therapist to recognize when BPD or other patients trigger their schemas and teach them how to work with their schemas when they get activated in the session. And this, just to pick an example here, it's very common for therapists to begin to feel inadequate working with BPD patients because the progress is so slow and it gets better, then they get worse. And we try to help the therapists to recognize that if they have unrelenting standards, they need to reduce their standards. It's not going to happen that quickly. And that they're not a failure because the patient relapsed. That's the natural course of working with BPD. But if the therapist has those as schemas, we have to work with them and almost do therapy with them to work on their own issues. And just to pick a more risky one, the third one down, becoming angry and resentful. There are a subset of therapists who work with BPD patients who, when the patient doesn't respond the way they want them to, they can't deal with the schema that gets triggered, and they deal with it by going into a mode in which they become angry and punitive toward the BPD patient. This is the most damaging thing a therapist can do other than abandoning and just telling the patient to leave. So this is where a therapist really needs help and therapy to work on the schemas, because if a therapist reaches the point where they're doing this, it's totally unacceptable in schema therapy to do this, and we see it completely as a failure of the therapist to learn how to deal with their own schemas and to learn how to deal effectively with their own feelings. So that's an important part of training therapists. The outcome research, now I actually did go through this, so I'm going to skip these slides and just go ahead.
Okay.
We're almost done.
Yeah.
Huh?
It'll adjust and then it'll pass.
Okay, and just a mention of a few, can we start now? And just to mention a few books that might be useful if you're interested in learning more about schema therapy. The first one, which is the main textbook for therapists, is called Schema Therapy. Practitioner's Guide is published by Guilford Press, and it's sort of the Bible of how to do schema therapy. And it does have approximately 100-page section in the book on how to work with BPD. So if you want to know how to do schema therapy with BPD patients, this would be clearly the best book to get. A helpful book for clients is Reinventing Your Life. It's a self-help book, readily available, and it goes through many of the different schemas. It's not specific to BPD, but since BPD patients have almost every schema, almost the whole book applies to them, and they find the book, while sometimes overwhelming at first, if they go through it slowly enough, they relate very strongly to the ideas in the book, and it does help them to develop a more sympathetic view of their own problem. If you want to watch me doing schema therapy, you can get a DVD, which is published by the American Psychological Association, videos, and you can order that from their website. And finally, visit our website, www.schematherapy.com. We have all sorts of things, including slideshows, a list of workshops that I do, and all of our inventories are on there. So there are many things of interest to clients and to therapists on the website. And the final slide has to do with further training. If you want further training, we do have a 1 or 2 year international training program here in New York City. We'll be taking applications soon for the 2009 training program. You can get individual supervision for our institute. And if you go to our website, all the workshops that I do, sometimes make a good vacation because they're mostly in other countries, so you get a chance to combine a vacation with a workshop. So that's a good place to learn more about clarity.